Today, we're embarking on the first of a several-part series talking about chronic fatigue syndrome, which really overlaps with fibromyalgia and has more in common with it, and many would argue is identical to fibromyalgia, just different points of emphases. But to do that, we'll be having a conversation over the next couple episodes with Dr. Avindrah Nath, as well as Dr. Joel Young. In this series, we're diving into one of the most misunderstood and often dismissed medical conditions, the chronic fatigue syndrome, known as ME/CFS, with Dr. Avindrah Nath. He's the intramural clinical director at the NIH and leading expert on neurologic infections. In this episode, Dr. Nath shares how his early work with post-viral syndromes during the AIDS pandemic led him to chronic fatigue syndrome and what drove the NIH to launch one of the most intensive studies ever conducted on the illness. You'll hear about research that involved metabolic, neurologic, cognitive testing, and how it revealed surprising overlaps and distinctions, and what was found that was different when they compared to controls or those without chronic fatigue syndrome. Some of the questions that we'll be looking at is why patients often report severe brain fog and memory issues, but standard tests don't show deficits. His team meticulously selected patients to eliminate diagnostic uncertainty, what the research shows about central sensitization and nociplastic pain. We'll talk about the differences or supposed differences between chronic fatigue syndrome and fibromyalgia, and are they just really different names for the same issue? We'll also be touching on, in this series, the connection between chronic fatigue syndrome and ADHD and why traditional neuropsychological testing is missing the mark when it comes to ADHD. If you or someone you know is living with chronic fatigue syndrome, fibromyalgia, or another invisible, mysterious long-term illness, and you don't want to miss this important series. We're going to be talking about chronic fatigue syndrome. Tell me about your background and why and how you got interested in chronic fatigue syndrome. And then we're going to be talking about research that you and colleagues did on the topic of chronic fatigue.
Well, thank you so much for having me on this podcast. I was really looking forward to it and an opportunity to talk to your audience. So I'm a neurologist, and I've been practicing neurology since I finished my training in 1986. And at that time, I started off with the AIDS pandemic and started seeing patients who had neurological complications with HIV. And over a period of time, you become an expert in CNS infections. Everybody started sending various kinds of infections. And then you get these post-viral syndromes. You realize that people have infections, they get over the infection, but these neurological symptoms persist. And so a variety of different infections have been associated with these post-viral syndromes. ME/CFS falls into that category because a lot of patients, not all, but at least a lot of them, will complain of some kind of infection that they had, and after that they develop these symptoms that they cannot get rid of. And there was a push from the patient population and from Congress and the media to NIH to do something about it. Francis Collins, who was the director of NIH at that time, convened a whole number of researchers intramurally, and then he decided that I should take on the challenge, which I agreed to do. But at that time, I was a little bit naive. I didn't know what I was getting into. But it actually has been a great experience and an opportunity to really tackle diseases that otherwise have been very hard to crack. And so we're delighted that we've been able to at least contribute to that literature and hopefully for the betterment of these patients.
Yeah, so obviously there's recognition with people who've been suffering and struggling, and then politically people trying to put pressure into research to guide, to help people in invisible and misunderstood illnesses like the chronic fatigue syndrome. So what then inspired you and your group to do the specific study that came out about a year ago? Like, can you talk about what led to that and then talk about what you found in the study?
Yeah. It took us a good 5-6 years to really finish that study. But the advantage of doing studies in the intramural program at NIH is that you can study patients really in depth that you cannot do anyplace else. The reason for that is that in other institutions, when you bring in patients, you're bound by what insurance allows you to do and what does not allow you to do. Otherwise, if you want to do a lot of things, it turns out to be cost prohibitive. The intramural program, the way it is set up is the whole hospital is paid for. So if you do an additional study, it, the nurses are already there, the chest x-ray, radiology, all these things already exist. So it's no added extra cost to us. So the machine's already paid for, the technician's already paid for, right? So the added cost is very little. The rooms are already there. And so we can bring in patients and do it in a very cost-effective manner that nobody else can do. And so we can keep patients who otherwise do not require intravenous medications or whatever, like you have in other hospitals. They can't admit people unless you have to do something really drastic to them. We brought them 2 different sessions, one time for a week and one time for another few days, and study them very extensive. So every aspect of them, what they eat, we put them in a metabolic chamber, what oxygen they're consuming, what carbon dioxide they're putting out, how much energy they take. We do EEGs on them while they're awake, while they're asleep. We did MRI scans. We did functional MRI scans. We did spinal taps on them. We took their blood samples. We exercised them, took muscle biopsies, skin biopsies, and did very extensive testing to try and see if we can get to the bottom of these diseases. Because your assessment of patients in a clinic is very limited to the few things that you can test on a patient. And the stuff that you send to a clinical laboratory is also limited by what the clinical lab can do. So these patients have already had that kind of stuff and they don't find anything. So what you really need to do is research level investigations. And that's what we did.
Yeah, so you were able to do a lot of things at a time, almost sounds like somewhat like a Mayo Clinic where you're getting multiple tests done within a week, lots of evaluations, but yet trying to see if there's anything that you can find that's unique or different to separate them. And just to give a little bit of details of the numbers, you had to try to, one, recruit people who had CFS, right? Yeah. And then you had to get a control group of people who didn't to compare to, correct?
That's correct, yes. So we did both. There are 2 aspects to it. Number one, let me just address the Mayo Clinic part. I love the Mayo Clinic. They do a fabulous job. You go out there, they'll do a very extensive evaluation on you. But we did what Mayo Clinic cannot do. And we did about 100 more tests than the Mayo Clinic could ever do. That is because we are a research institution. Mayo Clinic it's not that they cannot do research, but they don't do the kind of research that we would do. They do things largely in the context of clinical care. We do it for only one and only purpose, and that is for research.
Then talking about the details about recruiting patients, like
the recruitment, yes. So what we did was we were very selective on who we actually studied. We wanted to make sure, number one, that there was an infectious process that led to their syndrome. Second thing is we wanted to make sure they met every single criteria for ME/CFS. So there are all kinds of criteria people have come up with because they're all clinical criteria. And the problem is if you have a lot of criteria, that means nobody really knows how to diagnose the disease. Okay. But everybody will criticize you for not having studied the right patient population. So we wanted to make sure that it meets all the criteria. So we have no dissent. Not only that, we then had a panel of ME/CFS experts who had to adjudicate every case, and we had to be unanimous. Everybody had to agree, yes, this patient has ME/CFS. Okay. So the last thing we wanted is we're going to study a small population, and somebody comes and says, half your patients really don't meet the criteria, then your whole study is shot, right? So we wanted to make sure we're studying a really clean, pure population.
So what are these strict criteria for ME/CFS, and how do they overlap? Chronic fatigue syndrome and fibromyalgia are 2 distinct names, but the question is, are they the same or are they discrete entities? And that is one area of significant discussion. They have more in common, and often it's a point of emphasis. They are both chronic, debilitating conditions. They share similar features like fatigue, cognitive dysfunction, and pain, which has led to an ongoing debate about whether they are separate conditions, variants of a shared condition, or comorbid frequently. Let's break down the strict diagnostic criteria, symptom comparison, and insights from research, including Dr. Daniel Claw, who's a key figure in fibromyalgia and chronic pain research. What are the strict diagnostic criteria for CFS? In 2015, the Institute of Medicine criteria, now the National Academy of Medicine, are widely used. To meet the criteria, all three core symptoms must be present. The first is substantial impairment, inability to engage in pre-illness levels of activity lasting more than 6 months, accompanied by fatigue that is profound, new, not the result of an ongoing exertion, and not substantially alleviated by rest. The second criteria is post-exertional malaise. That's worsening of symptoms after physical or mental exertion, often delayed and long-lasting. The third criteria is unrefreshing sleep, plus one of the following, which includes cognitive impairment, also known as brain fog, as well as orthostatic intolerance. That's dizziness, lightheadedness, and worsening when standing. The fibromyalgia diagnosis is based on the criteria of 2016 revision from the American College of Rheumatology. It's diagnosed based on the widespread pain index, which is greater than 7 areas of pain in the body, and a symptom severity score of greater than 5, or a widespread pain index between 4 and 6, and a symptom severity score of greater than 9. What are the 19 areas of pain? That includes the right and the left jaw, the right and left shoulder, right and left upper and lower arms, the upper and lower back, the chest, the abdomen, the right and left hips, and the right and left upper and lower legs. And when we look at the symptom severity score, that includes a score from no problem to severe, including problems with fatigue, brain fog, and waking unrefreshed. And then there's also questions on whether or not there's depression, headaches, or pain or cramps in the lower abdomen. There has to be generalized pain in at least 4 or 5 regions, present for at least 3 months, and no other disorder that would explain the pain. And what we mean by that is you don't have metastatic cancer. Often you can have an autoimmune disease like rheumatoid arthritis. You can have lupus with these. You can have inflammatory bowel disease. These often are co-occurring in many people. So when we look at the symptom comparison, fatigue is indistinguishable between CFS and fibromyalgia. They're often present. And it's more often which one is emphasized. For many of my patients with fibromyalgia, fatigue is more severe than the pain. ME/CFS, that is one of the core features. Post-exertional malaise, that's considered a core feature of CFS, and that may happen with those with fibromyalgia, but it's not necessarily part of the criteria. Often it occurs when people have flare-ups, or it's part of the up and down nature of fibromyalgia, where people are doing a lot more exercise and doing a lot more work, and they feel exhausted afterwards, and then they start to feel better when they rest for a while. Both ME/CFS and fibromyalgia have unrefreshing, non-restorative sleep. Widespread pain is common in those with CFS, and it's a core feature of fibromyalgia. Both have cognitive dysfunction, also known as brain fog or fibrofog. The symptoms of brain fog include forgetfulness, difficulty recalling information or remembering where things are, concentration issues, struggling to focus on tasks or maintain attention, feeling like thoughts are processing slower than normal, difficulty following through with a conversation or following along, harder to stay on track, having difficulty understanding situations for some people, more confusion, and sometimes some mental haze or fatigue. These are symptoms that overlap tremendously with ADHD. Orthostatic intolerance often occurs in those with POTS, or postural orthostatic tachycardia syndrome. It isn't a core feature of fibromyalgia, it is less common, but also considered to fall under the umbrella of nociplastic pain syndromes. Depression and anxiety often co-occur in those with both chronic fatigue syndrome and in fibromyalgia. They are more frustrated than depressed because of the significant negative impact on their life of living with these conditions without any benefit. Often there's higher levels of anxiety, but these are not core diagnostic criteria. Irritable bowel syndrome and sensitivities are common in both. These often are sensitivities to light, sound, smell, touch, etc. So the question is, are these the same thing with different emphases? Dr. Daniel Claw, the leading researcher in centralized pain and fibromyalgia, argues that fibromyalgia and CFS are both manifestations of central sensitization syndromes, where the central nervous system becomes more sensitive to sensory input. There is considerable symptom overlap between fibromyalgia, chronic fatigue syndrome, irritable bowel syndrome, and others, with the likelihood that these disorders share common pathophysiologic mechanisms. He proposes that these are on the spectrum of chronic overlapping pain conditions, or at the time, central sensitivity syndromes, now known as nociplastic pain syndromes. He shared that fibromyalgia and CFS have amplified sensory processing in the central nervous system, particularly in the regions known as the insula, anterior cingulate cortex, and somatosensory cortices. Functional MRI studies support abnormal pain processing. So, whether or not these are the same, we can learn a lot from the research, and in this interview, we are going to get a chance to learn much more with the latest research from chronic fatigue syndrome to help this group of patients, which, depending on the eye of the beholder, may have chronic fatigue syndrome or fibromyalgia. I tend to use the diagnosis of fibromyalgia. Many of you listening may have been diagnosed with chronic fatigue syndrome, but will gain a lot of wisdom from what has been shared on this podcast. And those diagnosed only with fibromyalgia will gain wisdom from the rest of this interview with Dr. Nath.
Then we said, okay, despite that, what we're going to do is we're going to bring them in-house. We're going to reinvestigate them for a lot of different tests to make sure there's no other underlying disease that can look like ME/CFS. So we started off with about 500 patients, okay? And we screened them. We chucked out a whole bunch of them because we thought that they may have ME/CFS. It's not like that they may not have the disease, but they could have some other underlying disease on top of it that could then confound things. So we didn't want people who had ME/CFS for a very long period of time or were totally bedridden, because then they develop other comorbidities on top of it. Right? So then it'll become hard to sort out what is what. So we had these very clean parameters that they had to fit in order for them to come here. For even those individuals that we then finally brought to NIH, we found that some of them actually had some other disease that had been missed. No two patients had the exact same disease. One patient had myositis. We actually did a muscle biopsy, found he got all kinds of inflammation. He had a totally different disease. One person had a pulmonary embolism. Okay. So they were fatigued because they had a clot sitting over there and nobody knew about it. So on and so forth, we found a number of different diseases. One guy actually had cancer that was undiagnosed. So you can see that if you do $1 million workup, you actually do find things on patients that people have missed. Now, it's quite possible that if somebody continued to follow these patients for long periods of time, they probably would have ended up diagnosing these diseases. But at the time when we saw them, they had not been diagnosed.
It's important for clinicians to be aware that other co-occurring conditions like cancer can be present or develop later, and keep a keen ear to the clinical history and continue careful vigilance.
So now we found these really clean patients. Then we said, okay, yes, you need a control population. So now we match them to controls. Right? So if you have a 30-year-old woman, you want to make sure your control is close to that age and is a woman of the same background. And that way you have a good control population to compare against, because sometimes there will be differences based on age and sex and race and other kinds of things. And we wanted to make sure socioeconomic background. So we match it the best that we can. So that's how we selected our population to study.
How many did you end up selecting?
20.
And then they got a couple of very intense sessions of all of the different things. And you have the paper, and I'll have a link to it in the show notes for the podcast. Going into this, you have hypotheses, right? You order tests to investigate either your own, or this was part of a team effort, obviously, that you guys
Yeah.
spent and ladies spent probably years trying to know what are the tests we should do, correct? Can you talk a little bit about that?
So I should make sure we give credit to the people who actually did the stuff. And so there were at least 70 investigators involved. It was a large team of individuals here in their program. That's the other thing I have to tell you about NIH is that people are so dedicated. So we weren't paying anybody to do anything, right? In fact, a lot of these people used their own resources. We did it on a shoestring budget. And so we approached all the various researchers who had the world's experts in their own little area of investigation. And he said, listen, would you be willing to contribute your time and effort and see these patients and test them? And almost everybody said yes. So we did detailed neurological evaluations, neurocognitive battery, but we did it like a 3-hour neurocognitive battery. Every aspect of it we tested. We had all kinds of patient questionnaires that we collected all kinds of data on them.
Well, let's talk about something that comes up a lot in people with chronic fatigue syndrome or fibromyalgia. They often report issues with brain fog, trouble focusing, memory lapses, or finding the right words. This study confirms the lived experience by many with chronic fatigue syndrome and fibromyalgia, who in this study consistently reported more cognitive struggles across several domains, including attention, verbal memory, visual processing, and language. But here's the twist. When the researchers gave them standardized neuropsychological tests, their actual performance looked pretty much the same as the control group. There were no significant differences and no bigger drop-off over time. So what's going on here? Why the disconnect between what people report and what these neuropsychological tests showed? And how well do these neuropsychological tests even capture something like ADHD? We'll get into that in more detail in an upcoming conversation with Dr. Joel Young, who's done some fascinating research on the overlap between chronic fatigue syndrome and ADHD. But here's a quick spoiler. Neuropsych tests don't typically assess DSM criteria for ADHD. They're often not that useful and are quite expensive and time-consuming. So what other tests did Dr. Nath and his NIH team research?
We did brain imaging. We did transcranial magnetic stimulation, where you actually stimulate the brain. You give them cognitive tasks, and it can do functional MRI scans on them. So you can see where there's metabolic activity in the brain taking place when they're doing various kinds of tasks or when the brain is just resting. And then you look at their heart, you look at heart rate variability. We tilted them up and down to see if the blood pressure actually is regulated properly or not. Right? We did neurotransmitter testing on them. And then with the tilt table, we took blood of various sample sizes and looked to see what are the changes in neurotransmitters. Right? So that way you're collecting objective parameter. A patient can say, I feel this and I feel that, but you don't know if it's just anxiety or is it really a true phenomenon. And by doing these kinds of things, we can put objective measures to what the patient is actually experiencing. And then we looked at spinal fluid. Everybody had spinal taps done. And on the CSF, we looked at the immune profiling. We looked at the metabolic activity that's present in the CSF. We looked at the proteome that's present there. We looked at mitochondrial function in the blood cells. We looked at it in the muscle. We actually sequenced the entire mitochondrial genes there, see if there was any kind of difference. We extracted the mitochondrial proteins to try and see if there was any kind of differences there. So did a whole host of things, a lot of immune profiling, because that's one area of my expertise is try to look at the viral and immune profiling. And so we tested a lot of different hypotheses to define the syndrome. Can we actually understand? Patients complain of this malaise, post-exertional malaise. So we had two experts. What they did was they put together patients. They said, okay, tell us what you mean by malaise. And tell us when you do the exercise, now what do you think about malaise? And so we try to define it. So these are the words in the English language, but they mean different things to different people. And yet it's such an important part of the diagnosis that you've got to be able to understand that aspect of it. And you find that there's huge variability in what people actually mean by that?
I asked those living with fibromyalgia and POTS in respective Facebook groups to share what they meant by fatigue. Here are some of the responses.
No energy, exhausted, but can't go to sleep. When I do sleep, it's only for a short nap, then I'm back awake.
Everything hurts, like I'm trying to carry something too big to hold or carry. It takes my breath. I walk slower. I avoid conversation. I feel a fog come over me, and I can't think of the words to use.
I can feel like I weigh 300 pounds, and it's hard to move around like that. Just exhausted, depressed, and unmotivated. I've had to slowly cut out all activities. Full-time work is enough. I get home and I'm done.
Sometimes it feels like I'm wearing a heavy weighted blanket all day, trying to move around a body that feels very weighed down. Other times it's like having a bad flu. Basic tasks take way more energy than usual and tire out my body very quickly.
I feel overwhelmed, unable to think or focus like I normally do.
Everything costs energy, even breathing does. It feels like you haven't slept for a week. Your body feels exhausted and weak. I often feel sick of fatigue, exhaustion, and it can take up to days or sometimes weeks to feel a little bit better.
My body feels heavy. Everything feels like an effort to do. Makes me feel emotionally numb. No vitality, no energy.
Feel the need to just not do much and just sit or lie still. No excitement or get up and go. It's debilitating.
It's a feeling of utter exhaustion, like wading through mud up to your neck all the time. It's physical and mental. You'd love to be doing something, but body and brain says no.
I feel like my muscles are jelly and I'm stuck in cement, and even lifting my phone is impossible sometimes.
Like walking underwater.
I am a nurse and have been suffering from fatigue for years. I best describe it as all-consuming tiredness with full-body pain, like having a type of flu that never goes away, and where even a touch of skin causes more pain and draining feeling.
The fatigue was heavy, pulling feeling on my shoulders. I could not keep my eyes open, generalized weakness and tired feeling. It's so hard to put the feelings into terms.
Being in an all-day fog that doesn't lift, being too tired to do normal daily routines, and anything extra was immediately recategorized as unnecessary. Skipping social events because even getting ready was too much work. Chunking down tasks such as dishes, unloading some, taking a break, loading some, coming back to finish. Even showering was difficult. One day I could wash my hair, but there's no way I could also shave.
No matter how much sleep, never ever feeling rested.
I would become too tired to smile, to talk, to even cry, and sometimes to even breathe normally or to sit upright. I feared any social interactions or making any plans because I hated to let people down or go ahead and go and become even more exhausted. It was always an exchange of stealing energy from one thing and trying to put it somewhere else.
That's where we will end this week's episode. Stay tuned next week as we continue the conversation with Dr. Nath, exploring the science behind chronic fatigue syndrome and fibromyalgia.